Indeed, what an incredible honor to be here for this big celebration and thinking about the last 5 years. So just wanted to start off with this nice hopeful slide. This is fireworks. We really are due a celebration. It really has been a remarkable time period. Most of the advances in the last maybe 5 or 7 years. And there are a few areas in oncology in general that can really boast the kind of advancements that we've seen in kidney cancer in the last years. And so much of what we're doing and learning and doing is going to be influential in all other areas of cancer, because we learn from each other. Even though they're different cancers, we learn some of the ideas and the strategies. So as Deb pointed out, I gave a talk like this 5 years ago. You can see I used the same format as Deb used tonight, but I've moved on to newer formats in 5 years. And so I looked back to try and see what I said 5 years ago, to try to direct me a little bit as to what I could say. And although, you think it's no big deal for a doctor to get up and speak in front of a room full of patients and survivors and caregivers and that, it's actually very stressful, and I think Dr. Kapoor could probably speak to that. I've given talks internationally for 2,000 to 3,000 people audiences, but I get to use all my tools of the trade. I get to speak in jargon and acronyms and statistics, and I have tons of complicated slides, and I can talk about data and that. And then when you get a memo from Joan saying that you can't do that, you not only can't you talk about blood, but you can't talk about statistics and acronyms and things like that, it becomes a little bit more challenging. And certainly, given the members in the room and the familiar faces and people I used to look after and spouses and things like that, it's quite emotional. So I needed a little help. I looked back to try to see what I was talking about and to try to see where I could go forward. So that was my introductory slide 5 years ago. And this was, I talked about a number of things, but this was the gist of the talk. It was all about drug availability questions. So at the time, we already had data on the pivotal studies that showed that both drugs, Nexavar and Sutent, were useful drugs in kidney cancer. And I think they probably were even licensed in Canada, but all the issues were about funding. Were we going to get them funded? Were we going to get them paid for? Were the Americans going to get them and we weren't going to get them? How did the things work in Canada? What was the process? And we spent a lot of time talking about that, and then the other drugs that were newer at that time, temsirolimus and Avastin, weren't even really on the radar yet in Canada for funding and that. So that was most of my talk. So I think given some of the data I'm going to show you, you'll see we really have come quite a long way, and in no small part, a lot to the advocacy work of KCC, who really rose to the need to get this message out and to help get drugs funded. Now, I ended my talk. It was December, and it was right before Christmas, and Joan, is Joan still here? Joan will attest that I almost never give a talk without showing a picture of my daughter. Maybe I need to have more children, or I should have had more children. But basically, she keeps me sane, and I like to show the progress. So this was the picture that was taken the night before I gave the talk, and she was 5 years old, and she had seen Santa, and it was such a cute picture. So I ended it that way, and I remember Tony, really liked seeing that picture. So anyway, 5 years later, she's changed. There's no interest to see Santa anymore. But as you can see, she's dressed as Hermione Granger. The magic of Harry Potter is very much alive and well in our household. So 5 years later, what have we achieved? So I found it very easy to make this list of achievements, and I'm going to go through this a little step at a time. So we have 5 drugs funded and available, and more coming. We may not always like exactly how the government restricts our ability to use these drugs, but at least we have access to these drugs in most cases. And some of the key clinical trials asking some important questions are either started and underway or already completed and we're waiting for some data. So there's going to be a lot coming forward in the next short while. So this is this sort of slide that's shown at a lot of kidney cancer meetings, which really kind of is to give the sense of how rapidly things have been changing for kidney cancer. And I might just spend a few moments on it for those who are kind of new to this area. So you can see the triangle is meant to represent expansion. And you can see way back in about what would be the early, somewhere in the 70s, late 70s, the cytokine drugs were reported to have activity. And as someone pointed out, I was probably not yet in school, but Dr. Bjarnason was using them, no doubt. Right. He doesn't age. He's much older than he looks. He's got that Dorian Gray thing. And then you can see some of the milestones. In the mid-'80s, there was some data to suggest that high-dose IL-2 was active. A little bit later, we understood a little bit about this gene, VHL, that drives a lot of the kidney cancer. It was not until almost 2000 that we actually recognized that kidney cancer was made up of various different types of cancers, and it wasn't all uniform. And then things got kind of exciting around 2003 when some of the very first data came out that this new class of drugs, which we call VEGF inhibitors or vascular endothelial growth factor inhibitors, actually showed shrinkages of tumors in clinical trials, early clinical trials in kidney cancer, which was unheard of. It was absolutely unheard of, and people didn't believe it initially till it got more disseminated. And then you can see fairly rapidly over the last 5 years all the various drugs, sorafenib, sunitinib, temsirolimus, the mTOR inhibitor, bevacizumab with interferon together, the other mTOR inhibitor, everolimus, in the second-line setting, a new drug, pazopanib, and there's others. There's axitinib, and there's all sorts of others coming along the pipeline that were all licensed and then indicated. And I just want to point out, it was around 5 years ago that really important studies started to be designed and that's the arrow pointing to the adjuvant trials. So where there's no doubt these drugs are prolonging life in the advanced or stage 4 setting, in oncology, if you can use a drug in the insurance setting after a good surgeon goes in and takes out your stage 2 or stage 3 cancer, and then that demonstrates that you can cure another subset of patients in addition to the surgery, then that really is progress. And so it was around that time that those trials were started. Just for a little historical context, it's not like this is a new idea. We do this all over the place in oncology. There had been many clinical trials done in the past in kidney cancer with using some of the other older drugs like the cytokines. And unfortunately, not only didn't they seem to cure more patients, they tended to harm patients in the longer term. So trying this whole new class of drugs in this setting is a big step forward. We don't have the data on this yet, but this will be big news if it helps. So that's a lot of progress in 5 years. The next big achievement, I would say, is we have a better understanding of the side effects of these drugs. And Deb likes to tease about her diarrhea and all things, but it was a real steep learning curve for all of us, and experience really speaks for a lot. And we were using these drugs, but we had to get better at them and have better understanding of how to manage them. I always like to show this side because it's so important. The doctor says to the patient, I stopped taking the medicine because I prefer the original disease to the side effects. So that would be a medical oncologist failure, right? If you have a drug that can help people but they can't take it for side effects, you have to figure out how to work that out. And we also started to learn that we really have to learn the art of a therapeutic balance. You have to be able to weigh the benefits versus the harm that you can do to a patient, and make sure that the scale is always tipped on the benefit side. And that's not always an easy line to walk, but we certainly are getting better at it. Having side effects is unfortunately a part of that balance when you're treating a patient with kidney cancer. And there's been very comprehensive reviews that have been written and published in very prestigious journals on just side effect management alone, which is a big step forward in this area. So now I've lumped the next three together because they all overlap. More so than ever before, we have this really multidisciplinary medical collaboration. And what that really means is that your colleagues in different disciplines and you get together and talk about cases and decide what is the best to do. So a surgeon and a medical oncologist and a radiation oncologist might actually discuss the best approach to this disease and the best way to handle it. It's hard, and the sequencing of events is not always as straightforward. So we have that going on. And of course, we have KCC as this outstanding example of a patient survivorship group that has demonstrated strong leadership nationally and internationally. It's unbelievable, their international presence. I can tell a story. I was giving a talk on kidney cancer in Barcelona, and I was all, big international meeting and all proud of myself for being invited. And the big shot at the meeting introduced me, and just before we got on the podium, he goes, "Oh, I know all about you." And I was very flattered. And it turned out he knew all about me because Deb and Tony had told them all about me, which wasn't my own reputation. Anyway, I'll take it where I can get it. And then what we've done is we've also been working in multiple areas on relationships between sort of the academia networks, clinical trials groups, the pharmaceutical industry and government, and all of this has really been a complex, but has really helped move things forward. So as an example of this kind of collaboration, I bring up this picture I hope you can all see of the first Canadian Kidney Cancer Forum that we had in Mont-Tremblant in February 2008. And you can see, you probably recognize, you may see some of yourself in the room in this picture. That's me right there. There's Dr. Jewett. Dr. Kapoor, you're right there.
I'm the good-looking one.
You're the good-looking one there. And Tony and Deb. And so, and so many, what's so special about this is that in that picture, so you're seeing different physician disciplines from across the country. You have nursing, you have pathology, you have radiology, you have interventional radiology, we have policy writers, and then we have KCC, and we have patients and caregivers and membership and industry present, and we were all at the table and all in discussion. So we've done this many times since, but this was an incredible first meeting, and we wrote consensus statements and published them. So that's a huge achievement. And I think probably the most important advancement is that there is no doubt, it's difficult to measure this, but there's no doubt that patients with advanced kidney cancer are doing so much better than they ever have before. We can estimate the statistics and the survivals, and it's difficult, but there's no doubt it's been an absolute breakthrough, and it's like just awesome. So now I want to talk a little bit about the near future, and I hope we get here soon because this is where we need to go. And I think I'll take it one step forward realistically from prolonging life to turning it into a chronic disease. Cure is perhaps coming, but that's a more distant future. So in the near future, turning kidney cancer into a chronic disease, and certainly many people are writing about this and talking about it. A chronic disease is like you think about diabetes or heart disease or respiratory problems where that disease isn't cured, but it's managed with medical therapy, and you get on with your life and you don't live defined by that disease. It's something you have and you move on. And this I think there are examples already of patients with metastatic kidney cancer who have a chronic disease and are living that. And what we need to do is get that to be a more common occurrence. So the challenges with that is that we have to know how to optimize the questions we ask in the trial so we can get at this. And probably the most important thing is we have to overcome this problem of drug resistance. So as all of us are aware, the drugs can be very useful, but at some point they may stop being useful and we switch to another one if we have one, but we need more. We need to understand when and how to switch and have more options, and that's coming. We need to find the best sequence of drugs to use so that you get the biggest bang for your buck with the drugs that you have. And then we have to personalize these choices so that one patient's care plan is not exactly the same as another, and we have to know how to do that at baseline. And I don't know how to answer this, but we have to do all this without letting the costs run away with us so that we don't have access to these drugs. And this is a paper from the Lancet by Martin Gore and colleagues from Europe and Britain, and I think he summarized very nicely here this idea of this, and this a lot of people were talking about it at this time. You can see the picture on the top of the red circles are representing cancer cells, and you can see over time they're becoming more plentiful and the disease is untreated and progressing. And at some point, the burden of disease or the number of cancer cells makes the patient sick, and then that can be the beginning of a decline. And then on the bottom, the blue cells, you could argue that over time they are becoming slightly more plentiful, but at a much, much slower rate. And this is the treated side, and the patient would, in this scenario, remain well, relatively asymptomatic, and think of themselves as a chronic disease. We all talk about, or at least in the medical profession, everybody's talking about personalized medicine. It's sort of the holy grail, and it's where we want to be. And basically, it's an approach where you can look at someone before you treat them and know something about them and predict how they will do, so that you give them only the treatments that may work or have the best outcome for them. So this picture sort of shows a crowd of patients. All would have the same diagnosis, but they're not all the same. And you have one group, the red group, where they do very well and have a good response to treatment. Unfortunately, there's that middle group where they don't do so well and the treatments aren't so useful. And this might be a group where you want to really throw an alternative, non-standard approach to them because the standard isn't useful. And then you have the last group where, yeah, the treatments may work, but they have an unacceptable level of toxicity, and it would have been nice to know that at the beginning so that you could have warned them or adjusted in some way. So we all talk about this, and we really need to get more research on what these predictive, what we call biomarkers are, to try to identify where patients sit at the beginning and what is the best option to use for them. And we also need to have the sort of early tests like the X-rays that might be able to tell us very quickly that a therapy isn't working. So cut your losses, don't add any more side effects, and try something else. To be able to do this kind of stuff, we do need more research and we need more treatment options, but it's all coming. So I want to talk a little bit about drug sequencing, because in reality, this is what we do today in kidney cancer. So you can see there, drug A followed by drug B followed by drug C, and the patient's disease is controlled for a certain amount of time, represented by the yellow arrow on the bottom. So an old sort of paradigm in oncology is, well, if one drug works, then if you put more of them together, you're going to get a better outcome. It may be that if you put two drugs together, you might get a slightly better duration of control up front, but you get often with these drugs more than double the side effects, which is a problem. And then when you add drug C, it still works, but you can see that the overall duration of disease control was not as effective as sequencing one after the other. Now, In kidney cancer, we're definitely leaning towards the top passage, but we may find combinations in early trials that are much better than what I've demonstrated there. And then, of course, what we really want to do, and we have trials underway right now, is we want to know that if you switch the sequence around and use different drugs in different orders in particular patients, you're going to get a much better outcome or a longer disease control. And so we're working on that, and we're going to have some data on that soon. And then, of course, there's the next drug in the pipeline, and we see this all the time. We see it every couple of years, whereas we get yet another drug that can do something afterwards. And you can see how the progress isn't fast, it isn't overnight, but realistically, this is how we're moving towards chronic disease care. I want to say something about optimism, because I'm an optimist. So you can see this is a play on the cup half empty one. So there's the fish with his head above water. Whoa, half empty, definitely half empty, choke, gasp. And then there's me, just listen to you, always the pessimist with the head in the water. So I think with cancer and with all this hard work we're doing, we have to keep this optimistic approach because we need the energy, and we need to keep working. I wanted to show a few pictures, and Deb showed some of them already. And I went through my folders and I pulled some off the internet, and it was a very emotional journey. I can't tell you, as an oncologist, this kind of change doesn't happen very often in a career, and it really was remarkable. So here's a somewhat blurry image of the Fab Four that Deb talked about, Don and Paul and Deb and Tony, and she reminded me of the time that they like to come in and all share the examining room together. So I'll just put my spin on that side of the story. So as much as I adored these patients, each in their own way, they were kind of interestingly high maintenance. And if you could imagine all four of them together in the room, each competing for my attention, firing their questions, trying to outwit the other one, also while I was trying to get the job done and make sure that they were well and able to go on to the next appointment. Boy, I earned my money those days. I'd get out of that room, and I'd have to go have a little, splash in the bathroom before I could go on with the next 15, 20 patients. And of course, there's the dynamic duo of Deb and Tony. I think that was Ottawa or something, I think. And there's the famous Dr. Jewett with his right-hand woman, me, the assistant, no. And of course, Joan. Dr. Jewett has a way of delegating a lot of things to people, and that's one of those. And there's Dale and Wally, of course. And this lovely picture of KCC interacting with the PMH group. And I have Dr. Kapoor just to show that I remember that, he does do some work in Hamilton. And I wanted to put it there just in case he didn't come or something. I could remind people who he was. And of course, not my patient. I think it was Dr. Bjarnasen's patient, but Mark Daly died of renal cell this year, very prominent. And as Deb already mentioned, Rob Buckman, a colleague of mine, funniest man, talked to our group many times, said some of the funniest things about cancer I've ever heard, and we lost him this year. And Nina's not here, but Nina from industry has joined forces to help with KCC. This is a hockey team, and I don't know where this was taken. The forum, yeah. So those are mostly medical oncologists and some KCC support. Funniest looking hockey team I've ever seen. And then this is us, George, you're in that picture. This is us in ASCO. So interact, you can see how I have a much longer badge. He's not even watching. This is at our big oncology meeting, and where we bumped into Karen and Deb for a picture. So it was wonderful, just absolutely wonderful ride. So optimism. We certainly have achieved much. We have much to do. It's getting very complicated, but we have some really big minds working on this now, and a lot of data is coming forward. I'm going to leave you with this quote of the year from Jack Layton. I don't know if I can read it. It's hard, even though he didn't have kidney cancer, he died of cancer, and I think everybody watched his struggle very publicly. And he was cared for at PMH, and he overlapped with a lot of us, and all of us were just struck by his courage and his optimism right to the very end. So I do think his quote about optimism is better than despair is probably the best one of the year. So on that note, I will finish off. I want to congratulate KCC. It really has been an amazing first 5 years, and I'm very honored to be a small part of it, and thank you for your attention.